All right, well, let some folks get in here, but want to go ahead and start by saying good afternoon, everyone. At least if you're on the East Coast, good afternoon. Thank you for joining us. We have a very interesting topic today, and it's going to be led by our very own Vice President of Policy and Program, Gretchen Wardman. We're starting a series where we're going to have different folks from the NMQF staff speak about programs and policies that they've been working on. So no other better way to start with Gretchen, who's been with NMQF for, well, I don't want to say how many years, but she's been there since almost the beginning of NMQF. She's if you know DC, you know healthcare policy, then you know Gretchen. And so she's been in this space for longer than 20 years. And she's sort of talked about everything from brain health to prescription drugs to maternal health to Missouri to from Missouri to Michigan to now in DC. So without further ado, I turn it over to Gretchen.
Well, thank you, Brandon, I think. I'm pleased to moderate this first in a forward-looking series of webinars that are sponsored by the forum's recently inaugurated Institute for Equity in Health Policy and Practice. The Institute has been designed in response to the growing consensus that equity must be prioritized as the cumulative effect of a reimagined health services research delivery and financing system. A system that is proactive in reducing patient risk and supporting the biology of us all. It's a big ask, but it is not an impossibility. We begin this series of equity-centered webinars on the issue of prescription drug pricing. While the costs of all care must be examined through the interrelated lenses of equity and the reduction of patient risk, the immediacy and magnitude of prescription drug prices place them in stark relief relative to all other components of system costs. Given the limited time available to us today, and the complexity of our system of drug pricing, our remarks will barely fray the threads of this Gordian knot of an issue. But what we can do is begin the process of helping assure that this intolerable problem is not resolved with an untenable solution. I am joined this afternoon by three colleagues who will illuminate some of the options to constrain the growth of prescription drug pricing that are the focus of intense debate at the moment. Michael Ward is Vice President of Public Policy of the Alliance for Aging Research. The Alliance is the leading nonprofit organization dedicated to accelerating the pace of scientific discoveries and their application to vastly improve the universal human experience of aging and health. Michael oversees the Alliance's public policy and advocacy efforts. He has over a decade of experience advancing healthcare innovation through policy research, federal advocacy, and partnership development. Eric Gashow is Vice President of Policy and Government Affairs for the National Health Council. The mission of the National Health Council is to provide a united voice for the 160 million people living with chronic diseases and disabilities and their family caregivers. Eric leads NHC's advocacy efforts by working with its member organizations to develop policy positions that seek to improve the lives of people with chronic diseases and disabilities, and advocating for these policies on Capitol Hill and within the executive branch. And Gary Puckman, who is President and Chief Executive Officer of the National Minority Quality Forum. It was Gary's recognition of the need for a strategic reimagining of American healthcare that was the impetus for the creation of our Institute for Equity in Health Policy and Practice. Michael will first offer a perspective on approaches to redesigning the process that establishes prices within the delivery system that includes drug manufacturers, wholesale purchasers, payers, and pharmacy benefit managers. Eric will speak to out-of-pocket cost options that can reduce the burden for individuals and families. And Gary will offer a more macro perspective on the challenges of engaging different groups of stakeholders and consumers on the issue of prescription drug prices. For our audience, please enter any questions you may have in the Q&A box at the bottom of your screen, and we will address as many as we can after all presentations are complete. So Michael, I turn to you to get us started.
All right, thank you, Gretchen, and thank you to the National Minority Quality Forum. It's an honor to be here today. So there's a lot of discussion around healthcare costs, and a significant portion of the public debate has really focused on the price of prescription drugs. Unfortunately, in much of the debate that you hear in the media and on Capitol Hill, this focus seems to disproportionately reside on program sustainability, setting up a zero-sum game of winners and losers. However, what is too often missing from this discussion are the people that the Medicare and Medicaid programs are set up to benefit. While these other goals, they are laudable, they are important, and they are valuable for policymakers to consider, any discussion that fails to revolve around the patient is one that is more concerned about shuffling around responsibility rather than being focused on meaningful change that will impact the lives of beneficiaries. So it's fair to say that we all know that rising out-of-pocket costs in healthcare it's a huge issue, and it's attributable to many parties. For example, there are still people in the workforce that have employers that are looking for ways to reduce costs, that offer high deductible health plans, and are moving away from standard comprehensive benefits. We've seen more narrow networks, and I think the end result is of a lot of these moves are more substantial out-of-pocket healthcare costs in the form of premiums, deductibles, and co-insurance. So though many parties have a role in addressing patients' healthcare costs, policymakers have been really laser focused on prescription drug pricing. Drug pricing has been the central topic for healthcare debate on the Hill for at least the last 3 years. Spending for prescription drugs overall still makes up less than 10% of total US healthcare spending, but it is important to recognize that patients are facing a very significant and increasing out-of-pocket costs due to really the way that biotechnology and innovation has progressed over the last decade. We see more personalized therapeutics as companies continue to invest in finding new cures. So according to a study by the Kaiser Family Foundation, the average annual out-of-pocket cost for beneficiaries in 2019 for patients that required a specialty medication was more than $8,000 a year. Currently, this robust discussion around the structure of Medicare Part D, D as in David, benefit serves as the primary source of insurance for prescription drugs and for Medicare beneficiaries is ongoing on the Hill. While there are a number of different approaches to address the cost of prescription drugs within Medicare, many are focused on modifying the incentives for various parties. So I'll just do a quick run through of some of the proposals that are being considered currently. First is Part D restructuring, which would shift the percentage of liability between beneficiaries, insurers, and pharmaceutical companies within the 4 different phases of the Part D benefit. And so those phases, just for background, there's an initial patient deductible, then an initial coverage period. Then the third phase is the coverage gap, which was previously known as the donut hole, and then the catastrophic coverage phase. Generally, proposals have lessened Medicare's liability for costs for patients that incur the highest drug costs in that catastrophic period, and shift them to either payers and or drug manufacturers by varying amounts, depending on the proposal and on which sector that the authors of the bill want to focus their incentive realignment. Conceptually, by increasing the percentage responsibility that's due to payers, it would promote additional formulary and care management focus, whereas additional responsibility on manufacturers could potentially reduce prices. The second idea that we are hearing a lot about is an inflationary cap that would focus on the list prices that drug manufacturers establish and acquire, and requires manufacturers to pay a penalty if the cost of a drug increases above the rate of inflation without a justification. And this justification could include a circumstance such as an emergency loss of manufacturing capacity, as due to a natural disaster such as a hurricane, which we saw in recent years. So this type of policy could prevent sudden price increases, though there is some speculation that such a policy could result in higher initial prices for drugs. The third idea that we hear a lot about is addressing pharmacy benefit managers pass-through rebates. PBMs are in many cases able to negotiate significant discounts off of list prices due to their market position. The top 3 PBMs process over 75% of prescription drug fills. In many cases, the discounts that they negotiate with manufacturers then flow to insurers or to employers, who in turn agree to pay higher administrative fees in exchange for receiving those pass-through rebates. So there's considerable discussion occurring both in the administration and on the Hill to evaluate whether these negotiated savings should instead flow to patients to reduce their costs rather than to flow between the current parties. Eric will go into this more, I'm sure, during his presentation around, but there's really been a lot of work done by patient groups, including us, through a Project Loop initiative by NHC, by MapRx, and many others in the patient community to advance affordability solutions, including limiting patient overall liability and increasing Medicare beneficiaries' ability to pay for their drugs. So I think the solutions in that space really to work to ensure that regardless of the political calculus going around other provisions of drug pricing reform, policymakers understand that addressing patients' out-of-pocket costs is imperative. No one should have to decide between filling their medication and paying their rent or their electric bill. So, and we also believe that failure to address patient out-of-pocket costs leads to higher costs elsewhere in the healthcare system in the form of care complications and hospitalizations. So, and I think, the last big provision I'd be remiss in talking about, even though it hasn't been in every drug pricing proposal, it has popped up in the discussions of both parties over the last 3 years, and that's this policy of international reference pricing. So this is basically, in short, international reference pricing would base the prices that Medicare reimburses for drugs and pin it or base it on an index or an average of prices paid for in other countries. And I think it's fair to say this has an emotional appeal. Why is the US paying one price and the UK paying another? However, when you dig down deeper into the structural impediments to patient care that policy would actually create in the real world, I think it really merits it merits a reconsideration as folks are thinking through the proposal. So many countries that are referenced to this type of policy utilize the quality adjusted life year, which is known as the QALY, which was developed and first used in the UK during a financial crisis to ration access to healthcare and limit costs. Unfortunately, the same metric reinforces systemic inequalities and injustices that have existed in the healthcare system for a long time that really undervalue the lives of older adults, individuals with disabilities, and minority populations. The National Council on Disability, which is an independent federal agency, has repeatedly pointed out that proposed policies that rely on the quality are discriminatory and are likely to fall afoul of US civil rights law. And I'll just point to the National Minority Quality Forum's leadership in this space. So they published a white paper last year illustrating how qualities exacerbate health inequities. So given these clear implications, policies that rely on quality-driven pricing metrics should be prohibited, not embraced. And international reference pricing policies would also have a severe impact on medical innovation and access to new medicines. So the Congressional Budget Office offers a conservative estimate a couple of years ago that said that international reference pricing would reduce industry spending on research and development from between $500 billion to $1 trillion. And additional third-party analyses indicate that the policy could reduce the probability of new discovery of drugs by 80%. So I'll say that the Alliance for Aging Research has been concerned about the impacts of international reference pricing, in particular on Alzheimer's disease. That disease in particular has been so complex. It's been such a long road to try to find cures that are really new cures that are effective against the disease. There's been a really high failure rate in clinical trials in the space. However, the number of individuals with Alzheimer's will double over the next 30 years, and this will have an incalculable human cost, not to mention a cost to the healthcare system. So challenges that potentially that inhibit innovation for some of these spaces could cost more in the long run. So just in closing, I'll note that the example that I just shared illustrates the very real challenges that occur when policymakers reach for simplistic solutions to complex problems in the healthcare space. Policies that rely on the best available information from 30 to 40 years ago will also reflect the biases of that time, including an ignorance, willing or otherwise, of how our healthcare system has marginalized individuals of color and resulted in inequitable access to care. So we really have to operate in nuance as this discussion continues. We have to live in the tension, and we need to demand from policymakers that as they look to address the cost of prescription drugs, the solutions that they bring forth advance equity and elevate the patient to the rightful place at the center of the discussion. So thanks for your time, and I look forward to the Q&A.
Thank you, Michael. Eric, we'll turn to you. Could you give us more information on what's being considered to reduce the burden for patients, families, and communities?
Sure, absolutely. Thank you, Gretchen, and thank you for your presentation, Michael. So first I want to give a quick overview of who we are at the National Health Council. We were founded in 1920 as a trade association for patient advocacy organizations. Today, we have more than 50 of the nation's leading patient advocacy organizations in our membership. But what makes us unique is that we bring the perspective of the entire health ecosystem into our membership as well. So we also have provider organizations, insurers, pharmaceutical companies, trade associations, other nonprofits, and very proudly can say that National Minority Quality Forum has been a member for quite some time. And I'm really happy to have Gary Puckrin as one of our board members as well. And so our board is also multi-stakeholder, but over half our CEOs of patient advocacy organizations. So we really hear from all of the players in the healthcare field, but really make sure that our policymaking and our governance is controlled by the patient advocacy organizations. So over the last year or so, we've really been taking a long, hard look at ourselves at the NHC and within the patient community, and looking closely at many of the challenges and burdens we see on the patient populations in the current healthcare ecosystem. I think COVID has only shown an even brighter light on many of the disparities and inequities that exist. And so we've been proud to partner with NMQF over about the last year or so to really be thinking more holistically and transformatively about how we really re-envision the healthcare system to better deliver health equity. But in the meantime, we know that the issues that we're talking about today as it relates to affordability of prescription drugs and affordability of costs more broadly is an immediate here and now issue. So as we think about some of these longer term strategies that we really want to deliver change in the health system, what are some of those things that are kind of the here and now issues that are being debated on Capitol Hill and that we think really could deliver some meaningful change this Congress? And one such thing is looking at something that Michael referenced in terms of reevaluating and redesigning the Part D prescription drug benefit. So just as a little history lesson here, the Part D benefit was developed as part of the Medicare Modernization Act in 2003, which is really a great testament to bipartisan activities to really get us to, for the first time, have a prescription drug benefit in the Medicare program. Some of the challenges that were created by this bipartisan debate that occurred was that they had a set number that Congress was willing to pay, and it created the 4 phases of the program that Michael referenced. And I'm going to show a quick slide to show what the current Medicare Part D program looks like, what the benefit looks like. So you see here, and Michael kind of dug into this, but to show it in graphical form, we have currently have 4 phases of the benefit. The first is a deductible, where the patient pays 100% of the cost up to $485. Then you get into the initial coverage phase, where the beneficiary pays 25%, the plan pays 75%. We then go into the coverage gap, which thankfully was closed as part of the Affordable Care Act, and by closed meaning that the patients are no longer, beneficiaries are no longer responsible for costs within the donut hole, and currently has 70% of that paid by the manufacturer, 5% by the plan. The beneficiaries still continue to pay 25%, but it's not the significant amount that they paid previously. Then you get into the catastrophic phase, where, and this is the important thing that we really are looking to address here, the beneficiaries are at that point on the hook for 5% of all costs above $7,100. And for many people, this is a huge challenge and struggle to kind of put a finer point on what Michael said, deciding whether or not to in many instances to fill your prescriptions or pay your rent, your utilities, all the other costs that people are burdened with, to throw 5% of, in some instances, very expensive drugs onto, putting that onto people's plate. And so some of the things that we really want to see happen as we talk about some of these policies moving forward is to really turn this thing around and get us to a much simpler Medicare Part D system. So if I went through this quickly, if anyone's confused, you are not alone. It is a very confusing issue for beneficiaries to really be able to navigate through each of these phases, know how much they have to pay. They get their copay at the pharmacy counter. It's not always easy to understand. And then when you get to the quote unquote end by hitting the catastrophic phase, you're then paying 5% of all the costs that are going to the plan. And so this has become truly untenable for the patient community. The universe of options that are out there for beneficiaries looks very different. We have a lot of new drugs on the market that are very transformative in terms of the outcomes they deliver, but are also very expensive. And to have to continue to pay 5% on that in the catastrophic phase has really become a huge challenge and a huge burden on beneficiaries. So I'll stop sharing. So some of the proposals that are being debated right now have some very, while there are differences that Michael referenced in who pays what amount, where that limit is, all these things, the key elements that are consistent across all of them. One is shrinking it down into 3 phases, easier to understand. You have a deductible, a coverage period, and a catastrophic. And very importantly, taking that patient out of the catastrophic. I cannot stress enough how important that is. The Medicare Part D program is truly the only health benefit in this country that does not have a cap on out-of-pocket costs. You see it in the marketplaces, you see it in commercial insurance, you see it basically everywhere except for this program, which is designed to really help deliver care to our nation's seniors and many people who are disabled as well. So some of our most vulnerable populations are the only ones who are stuck in this system that does not have a cap on out-of-pocket costs. So some of the proposals that are out there would cap it at $3,100 per year. Some would cap it at $2,000 per year. And again, sort of there's differences in whether or not it's the manufacturer, the government, or the payer who pay for anything in the catastrophic. But importantly, the patients are out of it. And that is the most important thing for us. One of the other things, and Michael referenced this as well, is that it's really important as we think about out-of-pocket maximums that we're not thinking about these on a calendar basis. We've been calling for what's been now termed as patient smoothing in the ACA marketplaces since the ACA marketplaces were a thing. But every time we've commented saying that we should really find a way for patients to be able to pay their out-of-pocket maximum over the course of a calendar year, we're hit with resistance saying we don't really know any examples of where that's currently happening, how to operationalize it. It's difficult, it might have an impact on premiums. Get a lot of pushback, but as we've started talking about with the Part D program, it's been a very different conversation. I'm excited, and I know that's a lot of the great work that Alliance for Aging Research has done, that the MapRx Coalition has done, a lot of individual patient organizations have done, to really put this idea forward. Every single proposal we've seen that would redesign the Part D program would allow those costs to be spread over the course of a year. They're all done a little bit differently. I don't know that any of them are the perfect solution. I hope we can kind of talk about this a little bit more in the discussion. I know the Project Loop at Alliance for Aging Research has looked at better ways of doing this. But just to kind of put the patient perspective on this, out-of-pocket costs are under current regime and under current system, any maximum out-of-pocket cost is paid for over a calendar year. I don't know anybody who budgets on a calendar year. I don't know anybody whose income comes over the course of a calendar year. And to not be able to spread those costs over the year are going to result in people leaving their drugs at the pharmacy counter. If you're someone who maybe is taking one expensive therapeutic, maybe you're taking a combination of drugs that are the total adds up for you to hit the out-of-pocket maximum. You might do it in your first pharmacy fill. You might do it over the first few months of the year. You may not have that money in your bank account, particularly as we're thinking about this in January and February. You just came through the holidays. You maybe bought a bunch of gifts for your family. there really needs to be a way to inject this idea of spreading these costs throughout the course of the year into the Part D program. And we also think that by doing that really sets a good example for people who may be covered under other benefits as well. So again, really excited to see there's been a lot of momentum here. I think as we think about some of these solutions that can move forward, Michael talked about a lot of ones that we think are very problematic. We are aligned in that thinking. This is the one area where Democrats are on board, Republicans are on board, manufacturers are on board, payers are on board. There's going to be debate and conversation about sort of who pays what part of it, but conceptually, everyone agrees that this something needs to be done here. And it's not too often you can say that in Washington, D.C. So I'm really excited about potentially continuing the momentum and getting something done this Congress. And with that, I will leave it there and look forward to the discussion.
Thank you, Eric. I'm going to turn to Gary now, and I'm going to say that, Eric, when you were speaking, the reason I started smiling was because you said at a certain point, patients would not be responsible for the costs. And one of the lessons that was drilled into my head by Gary Puckern was that it's all our money. It's a function of where or how the system accesses it, but the individual, the families and communities pay for all of this. And so with that introduction, I'll turn it to Gary for 7 minutes to share his perspective on this issue with us.
Thank you, Gretchen, and Eric and Michael. Thank you so much for your presentations. I really just want to reiterate what Gretchen said. All of the $2 trillion in American healthcare comes from American households. For whatever reason, everybody loses sight of that, and everybody else thinks it's their money. But at the end of the day, every nickel, every penny, every dollar in the American healthcare system comes from the American household. And what are they buying? What they're buying is what I would describe, and what we work on at the National Minority Quality Forum, is mitigation of risk, right? Every patient who comes into the American healthcare system expects the system to lower their risk for hospitalizations, lower their risk for emergency room visits, lower their risk for disabilities, lower their risk for dying, while improving the quality of their life. That is the fundamental purpose of our healthcare system. But we often get distracted by that. We start to think that the purpose of the healthcare system is to manage financial risk. And so we spend a lot of time talking about financial risk and not patient outcomes, and how is the system performing in mitigating risk. And part of that, what's also being driven here, is that we're not looking at the numbers. So when you start to look at mitigating patient risk, you start to look at the numbers. And I want to talk about the numbers in relationship to prescription drug prices, because in our view, medications are infrastructure. We're actually building something here to take care of diabetes and cancer and sickle cell and Alzheimer's disease. And we don't think about it in the same way that we think about building tanks for our military and our Air Force and Navy. We think of those as part of our defensive infrastructure, and we don't cry about how much money we spend over there. But when it comes to our health and building infrastructure for that, we have a whole different frame of mind. Let's talk about the numbers for a moment. About 45% of all Americans get their health care through government health care insurance. Medicaid has now, because of Medicaid expansion, about 80 million people are in Medicaid, right? So there are no prescription drug costs in the Medicaid program. Now we can quarrel about the quality of the medications they're getting in the Medicaid program, but the point of fact is there's no out-of-pocket costs in the Medicaid program. We have somewhere around 59 million Americans in the Medicare program. Now, in the Medicare program, about 50% of them, over 25 million of them, they have their prescription drugs costs subsidized. So on an annualized basis, they're paying less than $100 a year for the care. You can go look at the numbers, and that's what you're going to find, that about 50% of all the Medicare beneficiaries in the Medicare program have their prescription drugs for under $100 a year. So that leaves us now with another roughly 25, 28 million people who don't qualify by income for the subsidy. And so when you go and you look at their numbers in terms of out-of-pocket costs, the average out-of-pocket cost is about $600 a year. That's what they're paying. And even when you hone in on insulin, because insulin gets to be part of the huge conversation, the average out-of-pocket cost in the Medicare program for insulin is about $200 a year. Now, I say that, and I have to, of course, remind us that the average household income of a Medicare beneficiary is $25,000. So these are not inconsequential sums for Medicare beneficiaries, and I don't want to pretend that they are. But what I do want to say is we are making really elaborate systems, putting elaborate systems in place because we're not looking at the numbers. We're not trying to understand where the problems are. Now, we do have about 10% of Medicare beneficiaries, based on the plan that they've chosen, who have very high out-of-pocket costs. Relatively speaking, they could be paying anywhere from $2,000 or $3,000 a year for their costs. If you look at the employer-based system, we have now about 47% of the American population is in the employer-based system. And that system is going to be overtaken by government health insurance. Government over the next 10 years will probably be the largest insurer of healthcare in the United States, even though I know everybody speaks about the government employee system, but that's certainly falling behind government-based insurance. What's happening in the employer-based system, as Michael suggested, is that it's cost shifting. Employers are trying to cut back on wages because in their minds, medication or even healthcare is our wages. And so what you see with the plans that they work with, what they're really talking about is how to lower wages. And one of the ways, techniques they use to lower wages is to cost shift and make the employee pay more. What's also assumed in all of this by the 1%, by those who have financial means, that the system is really going to work for them. And so what they're really concerned about is the cost that they may have to pay for their neighbor's healthcare, because they feel as if, guess what, I can pay for what I need. But here's the point. We can't build a healthcare system for the 1%. It's not possible because if you think about what it costs to bring a drug to market, to test it and to make it available, it is not possible to take a drug or develop medications or interventions or any of those tools for the 1%. So those who think they're being particularly advantaged by this system, because guess what? I've got the financial means to purchase what we're now denying others. What they're failing to miss is that really over the long term, they're actually elevating their own risk, right? The only way we can lower everyone's risk in the system is that we have to get on with the business of finding new therapies, of finding new interventions, and bringing them into the marketplace. Anything other than that is elevating patient risk, which is not the objective of the system. And that's why we talk about reimagining the system. This old system of having financial risk above patient risk breeds inequality. We're never going to get rid of health disparities if we're going to pay all of our attention to financial risk and not get it that we want the next generation not to have to deal with diabetes, not to have to deal with cancer, not to have to deal with Alzheimer's. That's where we want to go in the 21st century. In order to get there, it requires investment. And that investment is realized in the prescription drug and in the devices and all the other tools that we develop to manage our health. And so what I would close here with is really the admonition that we ought to look at the numbers before we start making decisions about what we're going to do in our healthcare system. And the numbers that we need to pay attention to are those that are associated with patient risk. If we sit around and think just about financial risk or even prioritize financial risk, then we are necessarily going to have inequalities, even for the 1%. They are not going to get what is really possible in this scientific explosion that is happening all around us.
Thank you, Gary. I want to go to Michael with a follow-up question, but when we get back to you, Gary, if you could speak a bit more to what may have been heard as a conflict, a disconnect between the presentation that Eric made about the $2,000 cap on out-of-pocket costs and your average of $600 per Medicare beneficiary is out-of-pocket costs, because somewhere in there, there's a median that we need to speak to, as well as the range of costs that people may experience. So going back to Michael, you mentioned in your presentation that some of Congress's proposals may not go far enough to ensure patient affordability for prescription drugs. Would you like to share a bit more in about 2 minutes?
Yeah, absolutely.
Okay.
So I think it's, I think that people on Capitol Hill are hearing, they hear from their constituents about prescription drug prices a lot and are aware of the issue. I think, unfortunately, to Gary's point, there is a lot of focus on kind of this shifting around of risk rather than kind of addressing the cost and prices that would allow people to actually access their medications. And so I know one of the proposals, just for example, that Eric was kind of talked about that we've done a lot of work on is around the smoothing benefit that would allow patients to pay their costs in installments. So the cap would kind of lower the maximum that folks be able to have to pay per year, but still $2,000, $3,100 a year can be a pretty big chunk, especially the way the benefit is laid out. People have that that deductible at the beginning of the year where they're paying the full amount, and then they still have to pay a percentage of drugs as they enter the coverage, the actual coverage phases of the benefit. So so smoothing has been in most of the comprehensive bills. I will say that I think that there needs to be a lot more work done there because some of the proposals just said it, smoothing can start whenever you have $2,000 in expenses or you have $900 in expenses per year. But when you have that $1,000 a month or whatever the number is that you're trying to hit, if you have $1,500 in drug costs at the beginning of the year, then you're left trying to weigh out what goes. Is it your health? Do you ration it? Do you try to take half a pill and not fully adhere to the medication schedule? So do you risk your health or do you pay for kind of your other basic life needs? And so what we've really been pushing on Congress to do is to do away with these thresholds. I mean, people should be able to access, if we're talking about making changes to beneficiaries that are helpful, everyone in the Medicare program should be able to access it, and they shouldn't have to spend X number of dollars in order to do it. So I think it's important just to not rely kind of on half measures or just kind of an introduction, but really encourage Congress to do the job and to do it correctly. That way they don't have to revisit this in a couple of years.
Thank you, Michael. Eric, just turning to the National Health Council's operations for a moment. The council consensus building process results in the articulation of domains and values that frame your responses, the council's responses to different health system initiatives. How do they inform those domains and values? How do they inform the council's analyses of drug pricing proposals?
Sure. So this has been a great tool that we've used at the National Health Council in the 12 years that I've been here. That really helps us go through a consensus building process through our membership. And then also really helps us evaluate proposals on a real-time basis. So essentially, anytime we take on a new issue, whether it be prescription drug pricing, a couple of years ago, we knew we'd be taking on Affordable Care Act repeal and replace legislation. We work with our members. We spend a few months to get these right. We ultimately have them approved by our board. And then once we actually have them approved, if any new regulation comes out, any new legislation is introduced, we're able to quickly read through them, say, do these meet the needs of patients, yes or no? Or maybe kind of some parts do, some parts don't, and can quickly respond to policymakers. And so essentially what they are a set of high-level domains and more specific values that are essentially principles, but they get pretty detailed. So when we look at things like prescription drug pricing and other healthcare cost reduction, we know that these are really important issues. We know that the details of these bills are going to matter greatly in terms of how they impact patients now and in the future. So really want to make sure that they're crafted in a careful way that we think will best deliver benefit to people with chronic diseases and disabilities. So, some of the things that we are certainly looking at very closely with anything that comes out. We really want to make sure that anything is predicated on what patients consider to be high value care. We want to make sure that we're not creating new barriers to access or limiting investment and innovation. We want to make sure that we're not creating other unintended consequences. And I think, one of the things we've talked about a little bit today, but certainly as we think about a lot of these, are we really looking at cost in a long-term view? We know that the government, we know that plans, we know that a lot of the stakeholders operate on a calendar year basis, but healthcare does not occur on a calendar basis. So while we may be investing in, a good example would be a cell and gene therapy, is going to have a very high upfront cost, but tremendous savings to patients and to the government and to the private industry moving forward. So how are we really thinking about these things long term? So these are the things that we certainly are communicating to Congress as important to us, and we'll continue to use them to evaluate any new proposals that come out. If you don't mind, I'd also like to comment on that disconnect that you raised and the thing that you had mentioned earlier about how it's all our money. I completely agree. I think that the key thing here is when we think about the out-of-pocket cap, for example, while it's all of our money, the costs are not being spread out through the entire population in a equitable way. So I think we've all seen the stat that, and these things come and go up and down a little bit, but it's about 20% of the population accounts for 80% of healthcare costs. We really need to make sure that for those who are the high users of care, they're not the ones who are being overburdened with the costs, and that those really should be spread throughout the system. And that's what insurance was designed to do. It doesn't do it very well in a lot of instances. So I think really making sure that we're considering the specific impact on particularly people with chronic diseases and disabilities and really spreading that better throughout the insurance system, I think is kind of what that's trying to get, what this cap is trying to get at. And I think where a lot of our proposals that we're looking at should really be headed. So just wanted to comment on that as well.
Thank you. And before we turn to audience Q&A, Gary, is there anything else you'd like to share on the cost issue or any other aspect of this conversation?
Yeah, I just want to pick up on something that Eric said. So I would endorse the fact that we shouldn't have formularies in Medicare. Medicare is what is called social insurance. What it means is you don't have an option to whether you want to subscribe to the Medicare program or not. It's a tax. I mean, that's how we got it. The Supreme Court said it was a tax, and that's how the Medicare program was built. And when you have a tax in which every American, based on their job, is contributing into the program, you can't pick winners and losers. And what formularies are designed to do are designed to pick winners and losers. They're not mitigated by patient risk, intensity of disease, ability to pay. None of those things go into a formulary. They're just a blunt instrument designed to manage financial risk, essentially. And so I think the government in the Medicare Part D program really did the American public a disservice, right? I mean, I understand the politics of why it got done, but it does breed inequalities. And if we're really about the business of lowering risk and getting rid of inequalities, then I think we need to rethink. And then in that rethinking, what we need to understand is what's built into the price of prescription drugs is risk, right? It's all those failures. Look at all the failures that we've had for Alzheimer's disease and other diseases in which, with great optimism, investments are made, but the science is the science, and they don't work. The model that we saw, I'm not suggesting this is how we should do it, but if you look at what happened with COVID, the government said, hey, if you can get it cleared through FDA as an EUA, we're going to buy it. And that really stimulated the investment and helped us to get vaccines very, very quickly into market. Now, Pfizer decided that it wanted to go its own way on that. But the point I'm making is, if we reduce the risk, help to reduce the risk for the development of prescription drugs, work on our clinical trial system to make it much more less costly and quicker to turn around. I think there are a lot of different places we can look at where we can lower the risk, lower the cost, and then take those benefits and use them to get rid of formularies in the Medicare program because they actually have no place.
Thank you. Thank you. Let's turn to audience Q&A. We have a question here that I know is Dr. Pucker would love to speak to. I'm going to ask Eric to answer first, then Michael, and then Gary. The question is, how should policymakers address issues of lack of access to preventive care and screening services in Medicaid that can lead to disproportionate burden of advanced disease in the Medicaid population? Then later stage diagnosis then may require more intensive therapeutic and procedural interventions that can challenge state Medicaid budgets. And so the part of the question is, the first part is that how do we address that lack of access to preventive care and screening services in Medicaid? Eric?
Well, here's one of many, many, many examples where I think the Medicaid program is not operating as it should. So I think the point is very well taken that the investment now in those preventative services, whether it be screening, whether it be smoking cessation, a whole host of things will have tremendous savings down the road. But unfortunately, the way that this is set up, the way the Medicaid program is set up, is that, again, looking at those calendar basis arguments, the state budgets have to be balanced on an annual basis. And so there's a lot of lack of will to really invest in some of those things that may have upfront costs that are going to have tremendous savings down the road. Personally speaking, and this is just me, but an area that we are looking to explore a little more in the National Health Council, there should be some federal intervention here to really help provide states with some of the resources, and I think in many respects requirements, as you see different states doing better job here than others to cover these. I think that there's probably many solutions that can be taken, but completely agree that this is something that we need to get a handle on. I think it impacts everybody, but it certainly, I think, impacts marginalized communities more than others. So I think it's an area that we would like to do a little bit more exploration. If anybody has any specific ideas, I'm all ears, but certainly know it's very important.
Thank you. Michael?
Yeah, I mean, I think,
give it a shot.
Yeah, yeah. I mean, I definitely don't have the silver bullet, but I think to Eric's point, I mean, whenever we hear a lot of these discussions on Capitol Hill and the Medicaid program, it feels like the discussion is always about, okay, how can we lower our expenditures on Medicaid moving forward? It feels like the solutions are around kind of restricting future growth and spending, which, like Gary said, a dollar is coming from somewhere. It's all coming back from the taxpayer. So those are important issues. However, I think kind of that focus on the dollar rather than kind of looking holistically at the whole picture of like, can we invest in extending coverage for screening? That way we prevent, colorectal cancer or whatever the case may be. Those are how we need to be thinking about these. And I think, unfortunately, just in the healthcare system at large, that, and it's partially an artifact of kind of the current system, is that, people can go from insurer to insurer each year in many cases. And so a lot of times the point of view is restricted to a very narrow frame of time. It's not looking at a person's whole life and their total healthcare costs. And so we need policymakers to really think in those terms rather than kind of those short-term savings. Think about how we can really make longstanding changes.
Thank you. Gary?
I would agree strongly with both Eric and Michael about the Medicaid program. It's broken, right? It's structurally broken because it's tied to the budget of states. What I would go on to say, it's an example of what we value and what we think of our healthcare system and the work it's supposed to be doing. Right? This is almost a cultural issue, which is to help everyone understand that the function of the healthcare system is to lower risk, not to elevate risk. To put people into a Medicaid program that is dysfunctional and elevates their risk and produces disparities and poor outcome is a failure. It's a system that is failing the American people. And the fact that we dither about it because we want to address financial risk misunderstands the nature of our society and what we're supposed to be doing by our social contract. So this goes deep into the whole issue of our social contract and what people should expect of their government. And I think that's part of the conversation that we have to have as we start to reimagine the healthcare system. It is part of that broader American experiment. If people go back to the founding text, they'll understand that the first words that were put into that Declaration of Independence was conservation of life. It got shortened to life, liberty, and pursuit of happiness. But the whole idea was we were giving up certain freedoms, which is a whole nother conversation, in order to come together because we felt that the collaboration together was better than us sitting in the state of nature, the Hobbesian state of nature on our own. And so it was that commitment that government made to the governed. And the Medicaid program is part of that. It's part of that for real. And so when we fail the people in the Medicaid program, we're breaking the social compact. And that would be my argument. And we need to take a moment to really go back and think hard about what it is we're supposed to be doing, because it manifests itself in the kind of healthcare system that we provide the American people.
Thank you. I'm going to, before I go to the next question in the box, my reaction to that question is that in that environment within which Medicaid is constraining access for what they consider to be legitimate financial reasons to certain preventive services, they are also now having conversations about finding some way to use QALYs and value assessments and apply them to the Medicaid population. And QALYs, I think the audience may know, is this quality adjusted life years metric that is used with that name or any other name to assign a value to the lives of individuals who are receiving, who are beneficiaries of different health plans. Medicaid is doing it. Concern about some of the proposals that are being considered is that those international reference prices, many of those countries use QALYs, and I think Michael mentioned that. The degree to which they're used in the commercial sector is problematic, but the notion that there is a differential among human beings in terms of the value of your life, somewhere between 1 and 0, with 1 being whatever is defined as a perfect year of life, health, and 0 being, I guess not, is in itself the essence of inequity. And I think should not be considered as part of any responsible approach to containing the cost of healthcare. So one of the questions, that's just my statement, do it as you will. One of the questions I think references Eric's slide, Eric's chart. And the question is, what is the government entity that would be paying 80% of the catastrophic coverage phase if the Medicare plan is only paying 15%?
Yep, just real quick, and this is where it gets a little bit complex with the system we have set up when we talk about Medicare plans. We're talking about private health insurance plans that participate in the Part D program. So these plans themselves in the catastrophic phase currently pay 15% of the costs, and then 80% are then paid through the Medicare Trust Fund, which comes from taxpayer funding. So to sort of shorthand that, coming from the government, but as we've been talking about, this money comes from all of us. But that's where that entity comes, that's where that pot of funding comes from that then is just dispersed out to make up those costs to the plans.
Okay, thanks. So we've come close to the end of our time, and I'd like to give each of you an opportunity to make a final statement on this topic. And I think we have enough for each of you to have 60 seconds to make a statement. And I would like you to answer the question, the technical question, which is, if you had your druthers, how would you change the prescription drug pricing and payment paradigm to enhance equity and reduce patient risk? Gary has already spoken to his concern about formularies, but Gary, if you have anything else you'd like to say, 60 seconds, and then Michael, and then Eric.
I would just reiterate the point that formularies breed inequities, and certainly we should eliminate them in the Medicare program. I would say the same thing about the employer-based system as well, that we're never going to get to eliminate disparities, and even more importantly, get on with the business of really fighting with these chronic diseases and other things that beset us if we're going to hamstring ourselves with weights like formulas.
Thank you, Gary. Michael?
Yeah, I think it comes down to, part of what it comes down to is we need to address this differential between the costs that people are paying out of pocket now versus what is kind of a reasonable amount to pay. That, you know, Medicare is the only program where you, as Eric said, that you don't have a maximum. And so we really need to make sure that Medicare as an insurance program for our elderly population, for our disabled population, is really meeting the needs of the population that it serves. And in doing so, coming back to the point is, you know, we need to solve that problem, but we can't fix it by installing other problems that will limit our ability to create new cures that may exacerbate and really reinforce historical inequities. So it's a balance, but we need to focus on the right side of the ledger rather than things that'll cause issues long term.
And Eric, you get the last word, and maybe just 4 of them.
Just real quick, I think we need a more rational system of pricing pharmaceuticals in this country, and I think it all needs to be predicated on what is delivering the best value to patients and how do patients define that. We need better data, We need better metrics. And all of these things really need to be by bringing the patient perspective and a diverse patient perspective into the research of drugs, into the development of them, and into the delivery of them. If we do all these things together, and pull this information all the way through, I think we can better reward high value care while eliminating overuse of low value care.
Thank you. And our time is up. Thanks to the panelists and to the audience for joining us in this first equity webinar. We plan a series of them for the rest of the year. Thank you so much and be safe. Bye-bye.
Bye-bye.
Thank you.
Thank you.